Bonne soirée et bienvenue à l'Assemblée virtuelle de la Fondation d'Hôpital de Montréal pour enfants pour un très rare aperçu dans les coulisses du Children. I am Renée Vézina, President of the Montreal Children's Hospital Foundation, your co-host this evening. Merci d'être avec nous pour cette rencontre virtuelle bien spéciale. Nous explorons les coulisses d'une opération complexe d'un bébé de 2 jours, né avec une partie de son cerveau sortant de son crâne, ainsi que la bataille ardue contre le cancer d'une enfant de 6 ans. Je tiens d'abord à remercier nos 4 invités. Dr. Mirko Gilardino, Chief of Division of Plastic Surgery at the Children's and at the MUHC. Dr. Roy Dudley, Pediatric Neurosurgeon. Monsieur Stephen Thériault, grateful father of Céane. And my co-host, the one and only, Terry DiMonte, beloved radio host on CHOM FM, who is graciously donating his time and talents to us this evening. Thank you, Terry. Time permitting, we will be taking questions from the participants. So if you would like to ask a question, please use the question icon accessible on the upper right-hand corner of your screen. We will try to answer as many as possible. Terry?
Thank you, Renee. Thanks for the lovely introduction. As always, anything that the Montreal Children's Hospital and the Foundation ask me to do is an absolute thrill and my great pleasure. We are going to be co-hosting, Renee and I will be co-hosting the town hall tonight, and we're going to start with some questions for Dr. Gilardino and Dr. Dudley, who you can see on the screen. Thank you both, doctors, for being with us today. Taking time out of your busy schedule as surgeons to sit with us. And before we get to the questions, I think this is important. I want to warn people who are watching us that we will be showing some photos of the little baby that has been operated on. And some of you may find the images quite graphic, but they do serve to showcase the unbelievable work that's done by the 2 surgeons with us today. So we just thought we would give you a heads up, but we think it's important. Dr. Dudley, I want to start with you. You recently performed an exceptionally rare and complicated surgery on a newborn with a rare condition that you may have to help me pronounce. I think it's Encephalocele. Have I got that right?
That's quite good, Encephalocele.
Okay,
yeah.
Can you tell everybody what exactly that is?
Yeah, so an encephalocele is actually relatively simple from a gross aspect. An encephalocele is a protrusion of a part of the brain through a hole in the skull or a defect in the skull. Most commonly, they occur in the back of the head and in the front of the head. But luckily, they're quite rare, as you said. You know, we think that about 1 in 10,000 live births, the babies have an encephalocele. And we don't know exactly the cause. We think it's something multifactorial, probably genetics and environmental factors play a role. But whatever happens, it affects the embryology or the very early development of the nervous system and the bone underneath the skin at the head. So in terms of embryology, we know that the skin and the nervous system start off as the same layer. They're one layer, and through embryology, the skin stays on the outside, and the nervous system, or the brain, in this case, stays on the inside. And bone goes between to separate the brain from the skin. But if the brain remains attached, the brain layer, as we can call it, remains attached to the skin in at least one little part, bone can't fill in that part. So a connection remains between the brain and the skin, and eventually, with just probably the normal pulsations of the brain and some pressure inside the brain as the brain grows, a part of the brain actually goes through that defect in the bone, and you have a massive brain underneath the skin. And that's what we had in this case, as you can see here.
The pictures really describe that. Renee?
Yes. Wow. Dr. Gilardino, originalement, vous aviez pensé attendre quelques semaines pour mieux planifier la chirurgie, attendre que le bébé puisse reprendre ses forces. Mais finalement, vous avez décidé d'opérer d'urgence et le bébé avait juste 2 jours. Pourriez-vous nous expliquer pourquoi et comment s'est passée la chirurgie? And Dr. Dudley, please feel free to jump in. I know this was a team effort.
En fait, comme Dr. Dudley a expliqué, il y a cerveau dans cette bosse entre les yeux. Mais cette liquide qui normalement existe autour du cerveau a commencé à couler. Cette fuite présente un danger immédiat à un enfant comme ça parce que ça peut causer une infection très importante autour du cerveau ou une méningite. Et ça, c'est quelque chose qui est dangereux pour la vie de bébé, spécifiquement à cet âge. Donc, on a pris la décision de procéder avec la chirurgie, d'essayer de réparer et reconstruire les déformités comme une urgence le même soir. En fait, je suis dans la salle d'op et Dr. Dudley m'a appelé de dire j'ai un peu de mauvaises nouvelles pour vous. Je pense qu'on va faire chirurgie ce soir. So, c'est pas un cas facile parce qu'un bébé comme ça, il y a juste 7 livres. Ça veut dire en total un volume de sang de 500 cc. So, ça, c'est un défi très, très important pour l'équipe d'anesthésie de procéder avec une chirurgie avec un jeune bébé qui est pas stable avec une grosse intervention craniofaciale. So, c'est comme une planification très importante. D'une façon technique, juste de vous expliquer, on a commencé avec une incision autour de cet endroit ici dans le crâne, un bon endroit de mettre une incision, de bien cacher les cicatrices, ou pas des autres cicatrices sur le visage. Dr. Dudley et moi avons commencé ensemble, après l'équipe d'anesthésie à préparer le bébé avec toutes les intraveineuses, toutes des choses de monitorer le bébé pendant la chirurgie. En fait, on a fait une exposition de crâne. À ce moment-là, Dr. Dudley a commencé son exposition qui s'appelle une craniotomie. Ça veut dire une incision dans l'os, d'enlever l'os et d'exposer le cerveau. En même temps, en extérieur, moi, je commence mon travail et ce travail est de séparer le morceau de peau de le cerveau entre les deux parce que c'est sûr, j'ai besoin un peu de cette peau de fermer le trou qui va exister en fait entre les yeux après la chirurgie, après le bosse était enlevé. So, ça revient à Dr. Dudley après, et ça c'est la partie très délicate de cette chirurgie parce qu'il a fait beaucoup d'attention de commencer à séparer la partie du cerveau qui est normale et de trouver cette trou, cette fuite en fait, et de séparer cette partie du cerveau qui est non fonctionnelle et qui doit être enlevée. Autour de cet endroit, Dr. Dudley peut expliquer ça dans beaucoup plus de détails que moi parce que je suis juste plasticien, Dr. Dudley est le neurochirurgien, mais en fait, il y a beaucoup des artères très importantes. Si on commence avec une blessure d'une artère dans cet endroit, ça peut être une situation très grave pour l'enfant. Comme ça peut en fait terminer dans une façon pas bonne pour l'enfant. So, en fait, quand Dr. Dudley a finalement isolé les parties de cerveau qui peut être comme déconnectées, il a fait ça. On a fait ça sans problème. En fait, le bébé est très, très stable pendant cette chirurgie grâce à notre équipe excellente d'anesthésie et les infirmières, c'est sûr. Et puis, j'ai recommencé en extérieur. J'ai enlevé le morceau au complet. Et puis, un peu de magique de chirurgie plastique, d'essayer de refaire quelque chose qui ressemble au nez. Parce qu'en fait, cette bosse déforme les orbites et en même temps la base de nez dans cet endroit. Et finalement, c'est évident, si on peut montrer encore le CT scan, je ne sais pas si ça c'est disponible pour nous de revoir, on peut voir qu'il y a un trou entre les orbites qui n'existe pas d'habitude. So, en fait, les orbites, il y a espace trop large entre les deux. So, on a commencé avec une petite chirurgie de minimiser l'espace entre les yeux. Ça, c'est d'habitude une chirurgie en réserve pour les enfants plus vieux, mais ça, c'est la seule chance qu'on a de normaliser le plus que possible l'apparence de cet enfant. Donc, quand on a été terminé, je pense, on a une photo pour vous de vous montrer un peu les résultats de ça. On peut voir qu'on est avec beaucoup de succès enlever au complet cette bosse et en même temps approcher les yeux. Et je pense que Dr. Dudley va expliquer un peu plus qu'est-ce qui se passe après la chirurgie. Je peux dire, juste en termination, ça a besoin d'une collaboration très intense entre les chirurgiens, les anesthésistes et son équipe, les infirmières, en fait, tout le monde qui a besoin de travailler ensemble parce que c'est juste une chose de faire une chirurgie complexe comme ça, mais c'est une autre chose de garder la vie d'enfant de cet âge. Ça, c'est un bébé de 2 jours qui pèse 7 livres, un total de 500 cc de sang, et c'est sûr, on a transfusé au moins 2 fois son volume sanguin. So, je remercie mon équipe qui a fait un job excellent pendant cette chirurgie complexe.
Dr. Gilardino, just before I turn to Dr. Dudley, this is astonishing to me that this is even possible. How long in medical history, like how long have you been doing this kind of thing with a team of that complexity on a baby this young? When was it realized that this was even possible? It's astonishing to me.
Well, I think the type of surgery that we're describing has definitely existed for, I don't want to say it's been, 5 years. It's probably 20 or 30 years that we've had the technology. Neurosurgeons have been doing incredibly complex work like this for a long time. I think personally what we can say, the achievements that have brought us a lot further is, number one, a recognition of the need to reconstruct some of the structures right away, as opposed to just sort of chopping things off. And I mean, clearly that's the important part. But I think we're off to a much better start if we can get the baby's eyes in a better position. So I think, quote unquote, the craniofacial techniques have improved. And I think no doubt, and I can't say this enough, you can do surgery like this, but can you do it safely? And that requires some expertise. Clearly we have an incredible neurosurgery team, Dr. Dudley with tons of experience. It's not my first day on the block. I've been doing it for about 15 years. And then on top of that, just a superb intensive care team preparing a baby for surgery like this, and then an anesthesia team who can take care of a child this small. So I suppose what's gotten a lot better is just working together as a team to safely do surgery like this. And I'll be completely honest, and Dr. Dudley can tell you, I've been in practice 15 years, and the only other one I've done has been with Dr. Dudley. These are rare diagnoses. These children, when they're born like this, frequently don't make it because there's just too much brain that's herniated, or it's a very small thing. This is a bit like the moons have to align to have a child born functioning with this massive sort of amount of brain sticking out. And so it's quite special when we have a case like this, and of course special for the parents too. So a very, very unique experience for all of us.
Dr. Dudley, let me turn back to you, and I guess the big question is, how's the baby doing?
Yeah, well, I mean, first of all, I just want to reiterate some of the things that Mirko said, because I think they're very important. I mean, he touched on the fact that it's a multidisciplinary team, and you asked about how long people have been doing surgery like this, and it's true. It's not surgery like this has been done for a while, but I think, as Mirko alluded to, there's many other factors that play a role. As he touched on the neonatal intensive care unit, there were probably babies born like this in the past who didn't survive, particularly if they had other malformations that this baby didn't have. And also this was known prenatally because of imaging that was done before the baby was born. So we knew on ultrasound and MRI even that this was going to be present, but we didn't know how big it was going to be. So that helped sort of prepare us. And then also, to make the surgery safe, we did MRIs and CT scans to make sure there weren't important structures like important blood vessels and the pituitary gland and optic nerves that were extending out through this thing. So, and then of course, as he touched on, the anesthesia team, the nurses, his entire team. It's a multidisciplinary effort, and I think that's what's made it safer and possible to do these surgeries without complications today. But back to your question, by coincidence, I just saw this baby in my clinic today. I think that's a total coincidence.
Fantastic.
And he's doing great. He's doing great.
Wow.
So he left the hospital about 6 or 7 days. We did the surgery on a Friday night, and I think he left Friday morning the next week. He's done very, very well. In these patients, we're often worried about seizures because seizures come from parts of the brain that are abnormal, particularly focal seizures, focal epilepsy. And even though we remove the part of the brain that's outside, because that's definitely abnormal, and if you put that stuff in, that part of the brain back inside, you will definitely have problems. But even though that's removed, there's probably little parts of the brain that are very close to that opening in the bone that are still abnormal. So these children are susceptible to having seizures. But so far, he hasn't had anything that's looked anything like a seizure. So we're quite happy with that. He's developed, it's very early, it's only 6 weeks after the surgery, but he's feeding well. His early development, he's smiling, he's following sights and sounds around the room. He has good grip in his little hands. So we're quite happy so far.
It's one of the things that I like to reiterate when we're doing radiothons or something like this for the donors watching. It really, to the layperson, it's almost hard to believe. I know as doctors, you're describing it in medical terms, but it's, for someone like myself, it's astonishing, not just from the pictures, but from the description. I mean, anesthesiology alone on a human being that size must be such an unbelievable challenge, and must take so many resources and so much practice that you couldn't possibly have, which to me makes everything that happens at the Children's so remarkable. This is, to me, remarkable.
Yeah, and we almost take that for granted as well. We're doing our job on one side of a drape, but the anesthesiologists on the other side are doing incredible work, monitoring these babies, tiny babies, monitoring with us the blood loss, monitoring the temperature. Little babies like this, it's difficult to regulate the temperature, and you get hypothermia. So certainly, kudos to that team in this case for sure.
What's the prognosis for the child moving forward? Are there going? I mean, you touched on it a little bit in terms of seizures, but are there other issues this child is going to face as he gets older?
Yeah. So the part of the brain that we remove, that abnormal part of the brain, is part of the frontal lobes, and the very distant part of the frontal lobes, what we call the frontal poles. So that part of the brain in a neonate, in a very young baby like this, probably does very little. And actually other parts of the brain can compensate. So from that standpoint, we actually think that he will do quite well. And studies have shown that maybe 60–70% of these babies can live normal lives, have normal development. In particular, if they don't have other problems. And two problems that they can run into are hydrocephalus, too much fluid on the brain, and other malformations in the brain. And luckily, this patient doesn't have any other malformations and doesn't have this problem of hydrocephalus. So I think he's going to do quite well. And what I saw in the clinic today, I know again it's still very early, but he's doing quite well. The other patient that Dr. Gilardino mentioned, we did his surgery 5 years ago, and he started school. So far, his development seems perfectly normal. He hasn't had seizures, and he looks great. So we're keeping our fingers crossed that we're going to have the same outcome in this case.
Just before I turn it back to you, Renee, I'm just curious, how long of a surgery is this, gentlemen?
So this surgery, it probably wasn't as long as we expected. Maybe in total, Mirko, correct me if I'm wrong, I think it was about 4 hours.
Oh, okay.
Yeah, probably technically for Dr. Dudley and I, it was about 4 or 5 hours. There was about 3 hours of anesthesia time on either end of that, meaning it probably took them 2 hours to get the baby ready, because there's lots that goes into a less than 1 week old baby. Just trying an IV in a baby that size is a skill set. So I think technically we started around 4 o'clock in the OR, Dr. Dudley, and I was home by midnight. So I think we could say it took about 7 hours total, and about 5 of that was surgery and maybe 2–3 hours of anesthesia prep time.
Renee, over to you.
Thank you. So, Dr. Gilardino, quelles sont les prochaines étapes au niveau de la chirurgie pour ce petit patient? Et j'aimerais aussi que vous nous parliez d'importance de nos donateurs pour l'unité de chirurgie craniofaciale au Children.
Donc, votre première question, c'est toujours difficile à dire parce que chaque patiente va avoir une évolution comme un peu unique. J'imagine que cette bébé va besoin au moins une petite chirurgie d'améliorer l'apparence de son nez et peut-être la fonction parce que, comme c'est évident, cette bosse ici a déplacé toutes les choses des structures antérieures de la nez, sur la voie respiratoire peut être un peu comme déplacée. Donc, on va attendre pour ça parce que c'est sûr, on va voir l'évolution. Comme j'ai expliqué, on a fait beaucoup, le plus que possible, en fait, d'approcher les yeux un peu. Là, juste pour vous donner une idée, à cet âge, c'est comme papier mou. So, on n'est pas capable de stabiliser l'os comme façon conventionnelle. Ça veut dire de mettre les plaques et les vis, et choses comme ça. Et on doit faire attention avec les nerfs optiques, tout ça. So, j'espère que le bébé va besoin juste d'une chirurgie pour le nez. Mais c'est possible, quand le bébé est un peu plus vieux, on va noter que les yeux peuvent être un peu plus proches. Ça, c'est une chirurgie qu'on fait. C'est une chirurgie complexe. Ça va être encore une chirurgie qu'on va faire ensemble avec neurochirurgie parce que j'ai besoin, Dr. Dudley, de faire une exposition encore parce qu'en fait, c'est une chirurgie de bouger les orbites en intérieur, en extérieur. Et cette chirurgie probablement se passe autour de l'âge de 7 ans, entre 7 et 8 ans, parce que les os vont être plus forts, les yeux plus stables en position. Et à ce moment-là, on est capable de faire une bonne, comme un repositioning, ça veut dire approcher un peu les orbites. Plus que ça, j'espère peut-être juste une révision de cicatrices si les cicatrices guérissent pas bien, mais jusqu'à maintenant, je suis bien contente avec la chirurgie. So, je pense que ça va être le plan pour cet enfant, mais comme j'expliquais, ça va être au besoin pour cette famille et cet enfant. Au niveau des les donateurs, tout ça, c'est sûr, on n'est pas capable de faire la chirurgie qu'on fait ici sans la générosité de la fondation et les donateurs. Très important parce que on a besoin de la support pour les équipements qu'on utilise. On a des budgets limités et on est capable d'offrir les services comme ça complètes avec les infirmières. On est une équipe très expérimentée et en fait, on a besoin de donner juste d'offrir les services comme ça. So, je peux dire avec I don't know how to say that in French. With the bottom of my heart, I thank our donors, and we cannot exist. On ne peut pas exister sans les efforts de la Fondation et les dons. So, merci encore.
Merci à vous. So thank you both for sharing this incredible surgery and giving us a bit of a sense of what goes on in the OR and what your job is like. Can you just in a few words tell us what you love most about what you do? I mean, it's extraordinary work, but just would love to hear what you love most about your job. Dr. Dudley, let's start with you.
So I think, you know, the thing that I like most, the thing that I love about this work is of course being able to help patients, babies, children, families, like the one we described here. You know, we mentioned a lot of, you know, I was talking about embryology and MRI, and you know, there's all this neuroscience and pathology we talk about. It's all very interesting, but I think that, you know, the bottom line, on a day-to-day basis, I love the fact that I can do this job and help people, or at least try to help people. You know, sometimes it doesn't always work out, but you know, for the most part, you know, if we can, for me to be in a position where I can help people, and you know, see that patient like I saw in the clinic today, this little guy now 6 weeks old, and he's doing so well, the family's so happy. There can't be a more rewarding experience, a more gratifying experience than that. I'm just so fortunate, so lucky to be able to do it.
Mirko?
I guess I would echo Roy's sentiments. I mean, he pretty well said it all. Thanks, Roy, for stealing my thunder there. But basically, What I would say is the following. I would say that as a plastic surgeon, unlike Dr. Dudley, I don't often save lives. But what I do think that we can offer patients, especially those that have craniofacial anomalies, is the opportunity to have a more normal life and to improve their quality of life. I think we take it for granted that we have a normal appearance, and I think some of these kids really struggle. And so what I find special is, like, again, it's not the saving of lives, but to help coordinate what I would say is a world-class team of experts that exist. And craniofacial surgery is all about mapping out a child's life and saying, look, at 3 months, you're going to need this procedure. And then at 6 months, I'm going to come together with ENT and neurosurgery to do this procedure. And it's all about trying to make it more comfortable and easy for the families. And that's done by having an idea, having a plan, and having a great team to execute that plan. So for me, that's what I enjoy about my work. I really like working with all the different specialties, and I'm so proud of our team. I think we have an absolutely world-class craniofacial team. So that's my favorite part of my job, is trying to help improve the quality of lives with the great people that we have around.
Thank you both. We're so very lucky to have you both at the Children's. Valerie, are there any questions from donors or from participants?
Not yet, but I encourage people to ask questions maybe for the end of the session. Dr. Dudley will be staying with us. Unfortunately, Dr. Gilargino has to leave us. But if you do have any questions for Dr. Gilargino, we can definitely pass them on to him after the webinar, if necessary. Thank you.
Great.
Dr. Gilardino, just before you leave us, I'm just curious. I want to ask you both that in my head, again, as a layperson who's just curious and trying to figure out, I think you both should be wearing Superman capes, to be honest with you. But the challenges of working on such tiny anatomies, how do you overcome that?
Dr. Dudley, you want to take a crack at that one?
Yeah, so it's something. So when we train so maybe when you're a medical student, so first you have an interest and you go to medicine, and you as a medical student, maybe you're drawn to some sort of pediatric specialty, and then you go into neurosurgery in my case, and you get some experience. When I was a resident, I rotated at the Montreal Children's Hospital and got some experience working on young children, young babies, neonates, and sometimes premature babies.
Wow.
Not even as big and not even as old as this patient. And I guess somewhere along the line you find that you have an interest, an appreciation for that sort of work, and it comes with that, and it's part of your training like anything else. But I remember being a resident, neurosurgery resident, training at the Montreal Children's Hospital back then, and working on small babies, and liking the fact that this is something very special. I mean, of course, in pediatric neurosurgery, and the same in pediatric, plastic surgery or craniofacial surgery, we get again the opportunity to work on all age ranges, because we have patients that are 18; those are adults. So we have preterm babies, neonates, young children, adolescents, and then 18-year-olds. So if you find that you're a person that enjoys dealing with all those different types of patients, small and big, young and old, and being able to talk with the families about these conditions, then it's something for you. That's the way I'll put it.
Is there less room for error when you're working on a baby that young?
Yeah,
certainly. So the very first question tonight that Mirko answered so perfectly was the concern about operating right away. As he said, we initially planned on waiting 3 or 4 weeks because of the challenges that we heard about. The blood loss, the hypothermia, the brain itself, and the blood vessels of the brain are very fragile at that age. You sometimes if you need to do something with the brain itself, you find the brain is very friable, very fragile. You just touch it and it almost seems to slough off.
Oh. So
that's something you have to again train for, but also again in that situation, it's the team around you, and it's the experienced anesthetists and people in the even the nurses and the patient assistants in the room when something goes wrong. Okay, we have to get blood. It's the team around you. So and the neonatal team before they come to surgery and when they go back to the neonatal intensive care unit afterwards. It's the team around you that has to be aware of the challenge, be prepared for the challenge, have experience with that challenge, and that's what gets the job done. So certainly, yeah, there's challenging aspects of operating on such young babies, but fortunately here, in this case and other cases like it, we've had the team to do it, and I'm very proud. As Dr. Gilardino said, I'm very proud of that team.
I'm sorry to interrupt, but I believe Dr. Gilardino has to leave us at 6 o'clock exactly. But if Dr. Dudley wouldn't mind, I do have a couple of questions for him that came in.
Oh, okay, sure. I'm sorry, Marco, I cut you off there, I think.
I don't want to rush you off,
perfectly.
but I know you have to leave.
I can stay on for 5 more minutes, so I'm good. I'll listen to one of the questions, please.
Okay, one of the questions actually was for both of you, so perhaps you could take it first. How many people do you have traditionally on your teams, your respective teams?
Well, if we're talking about our individual teams, we'll always have each a couple of residents, meaning neurosurgeons or plastic surgeons in training, and then a mixture of a few medical students that will be rotating on our individual services. So the OR can be a busy place because that means that I might have 3 or 4 people with me, and Dr. Dudley might as well. We each have a fellow, which means somebody who's a graduated either plastic surgeon or neurosurgeon doing extra specialized training with us. And then you have to start thinking about the people in the OR. So you've got anesthesia and their team and nurses and so on and so forth. So the OR itself can be a busy team. Perhaps the question might have been asking about our craniofacial team. And what I can tell you about that is our craniofacial team is multidisciplinary. It's not just physicians as well. You've got, nurses, audiologists, speech therapists, and then all the different specialties that play into dealing with a child that has a craniofacial anomaly. And so I always give a great slide that there's 18 different specialties that participate in the care of a child, not all of them every single time. So I hope that answers your question. It's quite a few people that will participate in the care of a patient, perhaps not all in the operating room.
Dr. Dudley, would you like to add to that, or?
Yeah, so I mean, I think it's it's very similar in terms of the people on our team. We have a resident and a fellow in the operating room with me usually, and then I say this to the parents and the children. The day you come for surgery, you're going to meet a lot of people. There's going to be about 10 people because there'll be myself, my resident, and our fellow. The anesthetist is going to meet you with probably an anesthesia fellow and an anesthesia resident. A couple of nurses are going to meet you. We have a scrub nurse and a circulating nurse, and then a patient attendant. And then if Mirko's and his team is involved in the case, there's going to probably be 2 or 3 other people that we're going to meet that morning. So it's a big team. Involving, just in the operating room, 10 to 12 people. And then of course we have, for our day-to-day team on the wards, we have our nurse practitioner, Julie Brouillard, and we have backup, in my case, I have 2 backup excellent neurosurgery colleagues. So if I'm in the operating room and something is going wrong, we have Dr. Jean-Pierre Farmer and Dr. Jeff Atkinson, neurosurgeon colleagues that can come and help out. So it's again, that's almost a theme of tonight. It's a multidisciplinary team that gets the job done.
I don't mean this to sound like a stupid question, but I'm going to ask it anyway. With that many people in the OR, it must be quite a coordinated dance. I mean, is there a plan before you go in, or is somebody in charge? Who's leaning in? Who's leaning out? How does that work?
Yeah, so I guess, with experience, a lot of people learn the dance. They learn the steps of the dance, but when new people are involved, they're slowly trained in the dance. I suppose, the anesthetist and the surgeon are co-running the show with the nursing team, and yeah, it's on each side. So the surgery team with the staff neurosurgeon and the fellow and the resident have their little dance, if we want to continue using that analogy or metaphor, and then the anesthesia team as well, and then the nursing team with the help of the patient assistants. But then together, together we also we work obviously very closely, and it's a coordinated effort. But yeah, so it's set up like that, and the most important thing is sort of being prepared when things go wrong, and often, nowadays we do sort of mock sessions in the OR when some sort of catastrophe occurs. We sort of do a mock session to see how we're going to react to it and see what we can do better in the future. And that's a big part of this, the whole education of this as well.
Thanks, Dr. Dudley.
I'm afraid we don't have time for any more questions, but we have noted the unanswered ones, and we'll forward them to the doctors to get you some answers.
Yes.
Thank you so
And
much.
I'd just like to mention that Aperçu Encephalocele, Dr. Gilardino is an important donor to your department. Thank you very much,
so
both
much,
of you.
guys.
Have a lovely evening, Dr. Gilardino, Dr. Dudley. Hopefully you can stay with us for the rest of this webinar.
Well, thank you so much, both of you.
Thank you.
All right, we're going to move on to part two. Bye, Mirko. Thank you. We are going to move on to part two by introducing Stephen. And Stephen is here to tell us about Cyan's story. Stephen, can you hear me okay?
I can hear you fine. Can you hear me?
Yeah, we can hear you fine. Thank you. Thanks for doing this. Thanks for joining us, and thanks for taking the opportunity to tell everybody Cyan's story. I appreciate that. Let's start there. What can you tell me about Cyan? Let's start with how old she is and what kind of personality she has.
So Cyan just turned 6 this past September. She's a normal little kid, loves to play, loves to watch movies, a little bit of a bossy temper, fantastic, full little kid, adorable.
Yeah, I met her briefly before she popped on camera, and she just seems terrific and full of energy. By the way, she's very busy, eh?
Yeah, she started moving around a lot. Between the chemo, she's getting little peps of energy, and every time she gets a good transfusion, you can feel it that she's got a little bit of a boost.
Fantastic. So on that note, take me back to July. Take me back to the story when Cyan comes to you and says her tummy is hurting.
It actually started a little bit before July. So in about the month of March, we had noticed that she was gaining weight, and we chucked it off to COVID isolation and eating wrong. And for some reason, she was the only one of the family that was gaining weight. And about 2 weeks before the beginning of July, she had started complaining about tummy ache to a point where mom had tried to take 2 appointments with her pediatrician, and for COVID reasons, they were both canceled. And one night she had complained so much that mom brought her to an ER outside of Montreal, and they did her vitals and told her it's a tummy ache, go home. And a week later I had her, and she was complaining here that she had tummy ache. Again, I thought it was some kind of constipation or what have you. And I have a doctor in the family that I had called and went through the symptoms that she had, and he told me it looks like it could be appendicitis or something like that. So on the 5th of July, when I got into the Children's Hospital, it was, just to give you an idea, I got there at 5:20, and at 5:41, I was getting scans done. It was insanely quick. And again, at that point, when they had told me, maybe you should call mom, we're going to do a few more tests, I was thinking, all right, it's really presenting like appendicitis. And it wasn't till about midnight that we met the oncology team, and our entire lives just, I don't know how to explain it. It just stopped. Everything seemed to come to a complete halt.
Within the space of 20 minutes.
Well, the first 20 minutes, I'm now knowing what I know now, I know that they probably knew what it was,
Okay.
and just didn't want to throw it out there without going through the proper steps. and confirming, you know, who would want to announce to a child that your child has cancer without being 100% sure.
Right.
Again, when I met the oncology team, I met one oncologist, and yeah, I think that was around midnight, and my life just, everything became irrelevant in an instant, and I was taken aback by how sympathetic, you know, given that news, how sympathetic the team was, and how well in hand I felt that they were taking us. You kind of, you know what's going on, but you don't quite understand it. I don't know if that makes sense.
It does. It does. Yeah. One of the glories of the Children's Hospital is exactly that. And I've heard these stories over the course of the years that I've been sitting in on the radiothons. All parents to a person all say the same thing, that one of the great things about the teams is their empathy and their kindness and their understanding. And it sounds to me like you encountered that right away.
Oh, from the get-go.
Yeah.
And still encountering it today. I mean, we're in and out of there all the time now.
Renée?
Sure. Alors, Stephen, il est difficile d'imaginer ce que vous et la maman de Céane avez dû ressentir lorsque vous avez appris que votre fille était atteinte de cancer. Alors, qu'est-ce qui est arrivé par la suite? Quel traitement pouvez-vous nous amener là, vers aujourd'hui?
Bon, Céane a été diagnostiquée avec un cancer du foie, un cancer quand même assez rare. Puis il était au stade 4, donc il y a eu des métastases qui se sont promenées dans les poumons. La tumeur principale grossissant à un rythme tellement rapide qu'on a dû faire de la radiation pour cesser que la tumeur elle écrase ses poumons. Je ne veux pas me tromper dans les dates, là. On est arrivé le 5, puis je pense que le 8, elle a eu sa première traitement de radiation. Simultanément, on a commencé la chimio. La radiation a réussi à faire cesser que la tumeur principale continue à grossir d'une façon exponentielle. Et puis, ça a permis la chimio à faire un effet. En fait, comment on se l'est fait expliquer au départ, l'objectif, c'était de réduire le cancer principal suffisamment et se débarrasser de les métastases pour tenter une greffe du foie. Et en cours de route, il y a eu des changements. Je ne sais pas à quel point vous voulez que je vous l'explique, mais la chimio, elle a eu un effet. On ne s'est pas débarrassé de les métastases dans les poumons. En date d'aujourd'hui, Céane elle a réussi à rapetisser la tumeur principale à un point qu'ils ont réussi à faire une opération du foie. Et ils ont extrait la tumeur principale en enlevant 70% de son foie. Il lui reste un petit bout de foie, 30% pour être exact. Et dans ce bout-là, il y avait des métastases aussi de la tumeur. Il y avait de l'air plus à être vivable, donc plus en vie. Puis on continue les traitements pour tenter d'enlever qu'est-ce qui reste dans les poumons.
OK, merci.
Stephen, I'm astonished by the challenges that obviously Céane faces with her battle, and also always been fascinated and astonished by how parents handle the questions that come from somebody Céane's age. And I was told the story about her being upset when her hair started to come out because of the treatments, and she was begging you to make it stop. How did you handle that, and what turned it around?
So I remember that so clearly. We were taking a bath at the Children's, and she loves that bathtub because it goes up and down, and it's the most amazing bathtub in the world. Right. And her hair was kind of like falling off her head and getting in the way of her toys. And I started combing it, and you know that chemo does that, right? But you don't know what it does until you're sitting there. And I was combing her hair, and chunks of it was coming out. And I realized that, you know, in a matter of a day or two, she was going to start losing chunks of it off the top of her head. And she was telling me, we got out of the bathtub and we dried her and everything, and she was playing and it was falling everywhere. And she looked at me, she goes, I don't, the attitude came out, you know, I don't want this, get it off of me. So as you can see, I'm still partially shaved. Child Life, I don't know if everybody knows what Child Life is, but Child Life is one of the organizers from the foundation, I believe. Sabrina had passed by and overheard us talking about this hair dilemma, and she came in with that fantastic Barbie that you can see on the screen, Barbie. And next thing you know, San was telling me, I want my head shaved, I want a wig, I want a bandana. And within a few days, we were, she shaved my head and I shaved her head, and she shaved everyone else's head in the family. and it went off great. So no, kudos to them. They made that transition so much easier. And I think that if they wouldn't have been around, it would have been a little bit more difficult to explain to her that it was inevitable that she'd lose her hair.
With a little help from Barbie.
Oh yeah, Barbie, bald Barbie. Didn't even know she existed until then.
That's fantastic.
Actually, Child Life is actually a department of the Children's that offers this type of service very close to not only the child, but the whole family. They take care of the whole family. And this is really in the DNA of the Children. And people from around the world come to the Children's to study this group's ways of dealing with the health and with the trauma and with everything that the families are experiencing when they are at the Children's. So thank you to Child Health, definitely. Steven, Céane et vous avez un petit rituel avant le dodo le soir en observant les étoiles. Est-ce que tu peux... qu'est-ce que c'est qu'elle souhaite, Céane? On s'en doute un peu, là, mais qu'est-ce qu'elle dit?
Fait que Céane, le soir, on se promène à la fenêtre avant le dodo et on regarde dans le ciel, puis on cherche des étoiles, puis elle fait un vœu, wish upon a star. Et puis à tous les soirs, quand on était à l'hôpital, elle souhaitait que le cancer disparaisse, que les piqûres dans le port arrêtent de lui faire mal, et puis que tous les prélèvements sanguins arrêtent de lui faire mal. Elle faisait ça tous les soirs avant le dodo. Excusez-moi, j'ai mon petit gars derrière moi.
On adore les enfants.
That's heart-wrenching, Stephen. I know that Céane has been in the hospital, you know, during this most unbelievable time with the pandemic. I would imagine it's had all kinds of impacts on the services that are able to be provided in different ways. Can you tell me about how dealing with this illness during COVID and the pandemic has affected you in terms of what extra things you have to deal with?
It's funny. I've had a lot of time to think about that. I think that there's so many things that go on at the Children's, so many volunteers and people that come around and help. And I've been told that it's been drastically reduced because of the COVID pandemic. And I can only imagine how much better it would have been without this pandemic around. Because without them, I don't think we'd be anywhere near where we are now. The morale, the support that they give you is insane, for a lack of better words. I think that one of the hardest parts with the pandemic is the fact that we don't get very much support from family or friends from the outside. So, you know, it has to be mom or dad. Siblings aren't allowed to visit, so that was difficult. Lots of protocols. I mean, Céane must have had upwards of 15 COVID tests since she's been admitted. Yeah, so it's definitely not a good thing, but at the same time, I was explaining to one of my buddies the fact that we're in a pandemic and everyone else is in self-isolations. I don't need to explain to anybody why I don't want to be near anyone else. So it's,
Right.
you know, it's just, so I guess it's a two-tier thing. And in a sense, it couldn't have been a better period because I don't need to explain to anybody why I have a neutropenic child at home that can catch anything, and I don't want to see anybody right now. because I don't want to put her in danger. So, you know, in a sense, it's kind of helped in a way.
I guess one of the things that I know is common at the hospital is parents get to interact with other parents and share their experiences. I guess you haven't been able to do that, have you?
It's funny because parents that go through something like this, I don't think anyone else can understand other than another parent.
Right.
So, you know, when we're in clinic, you know, in the day clinic, we're in beds apart from each other, and there's a curtain that kind of hides us, and we can see other parents, and we do have some interaction. But I've been told that before pandemic, you know, the parents really supported each other a lot.
Yeah.
And no, we don't have that in-depth or that much support from other parents, because everyone's scared for their own child, and you know, nobody really wants to interact. Nobody wants to take the risk.
Renée?
Alors, pouvez-vous nous dire rapidement quelles sont les prochaines étapes pour Céane au niveau des traitements?
Donc, Céane, elle a fini le premier cycle de chimio, et puis elle a eu l'opportunité de faire une opération du foie, et on a débuté un deuxième cycle de traitement avec 6 séances de chimio qui vont continuer. Il va y avoir une opération des poumons qui va se faire probablement en début d'année pour tenter de voir si les métastases dans les poumons ils ont cessé d'être actives. Et puis par la suite, si tout va bien, on va probablement enlever tous les morceaux de cancer dans les poumons. Ensuite de ça, ça serait de voir si elle pourrait tomber en rémission, qu'on souhaite tous.
Ben oui, oh mon Dieu. On va prier pour vous, définitivement. Merci.
Stephen, let me ask you just before we let you go, first of all, merci mille fois, because these stories are so difficult to share. You've got so much on your plate. It's very, very kind of you to share the story with, you know, with people who are watching, donors who help out the hospital and get to find out how amazing the hospital is through things like this, you know, webinars during COVID. What can you tell people? What message would you like people to know about the Montreal Children's Hospital, about the doctors, the treatment, the people there? For the folks who are watching, what's your message to them?
I can give you a little bit of an idea. Every time a nurse comes into our room when we're there, Sam says, "Oh, that's my favorite nurse." And there's got to be like 45 different nurses, and every single one is her favorite. For a bunch of, they're all different, you know, but they're all so amazing. You kind of feel like they become. I was telling one of the nurses, yeah, I feel like they become like your best friends. It's ridiculous how they're not just medical staff. They come in and they take the time to listen to you when you don't feel good. And believe me, there are days you don't feel good. And they you know, especially in the evenings and at night, the nurses will stay in the room for half an hour, an hour. Obviously, if there's an emergency, they run out, but you know, they take the time to explain to you, and same goes for every single oncologist that's there. When we started this, you know, you're worried, you're at the hospital and you're like, am I in the right place? Is there a better place for me to go? And you start, anyways, I know I did. You start going online and searching and finding out, is there somewhere better? I wouldn't wish this on anybody, but I think out of all of this badness, we were in the best place on the planet to have a sick kid. And you know, there's people that come around from around the world to this hospital for their children. And you know, I don't wish it on anybody, but if there's a place to get your kid, if your kid's sick, this is the place to go.
I always say whenever we talk about the children's, you know, all the staff are unbelievable, but there's nurses are sprinkled with something special. They've got a special, you know, there's just something very, very angelic and special about nurses. And I know what you mean about at nighttime when it's darkest, you know, metaphorically and literally. They're such special people. That was beautifully described, Stephen. Thank you.
Yes, thank you.
Thank you guys for everything you
Thank
do.
you. Thank you very much. And yes, you know, she is in the best possible hands. That you can be sure of, you know.
I have her lurking. Do you guys want to say hi?
Yeah,
Oh,
yeah,
yes,
there, yeah,
absolutely.
And viens ici.
let's.
You want to say hi to everybody?
Come on, camera. Hi, Sam.
Hello. Hello. Ça va?
Sorry, got her NG tube in her nose.
Your dad was just telling us about all your favorite nurses.
Which one's your favorite nurse? They're all your favorites.
Yeah.
Can't decide.
No.
Oh, I didn't even tell you guys. One of the oncologists there is an artist, and she draws for San.
Yeah, and her name is
Dr. Monica.
Dr.
It's fantastic, honestly, guys. The best place in the world, and as you can see, they're doing a fantastic job. She kind of, if she wasn't bald, you'd kind of think that she was a normal little kid.
Yeah, fantastic.
Great.
Thank you guys so much.
Nice to see you,
Thank you.
Sam.
Say bye.
Nice to see you. Bye.
Nice to see you.
Okay, bye. Adorable, Stephen. Absolutely adorable.
Thank you.
So thank you
Bye-bye.
again to our two doctors who are helping the sickest children of Quebec to get better. Thank you, Stephen, for sharing your heartbreaking story. And thank you, Terry, for being such an amazing co-host.
It was a
Avant de
privilege.
terminer, nous aimerions partager avec vous la vidéo de notre campagne publicitaire Longue vie aux tannants, lancée en novembre, qui fait écho à la campagne de financement de 200 millions pour stimuler l'innovation en soins de la santé, en recherche et en enseignement aux children. Parce qu'un enfant en santé déborde d'énergie et parfois un peu tannant. Nous vous invitons à célébrer avec nous le petit côté espiègle des enfants du Québec. Alors, Jennifer, si on peut visionner cette courte vidéo de 2 minutes.
Renee, I've never seen that before. That's quite an emotional journey. That little that video. That's beautifully done.
Thank you, thank you. It's going viral on the web. It literally
bet
is
it
going
is.
viral.
Wow.
Yes.
Yeah,
Yes.
spectacular. Wow.
Thank you. So on that note, on behalf of everyone at the Foundation and the hospital, thank you for making the holidays a little brighter for our patients and for helping us find unexpected ways to heal. Meilleurs vœux pour la saison des fêtes de notre bulle à votre bulle et je vous souhaite une excellente soirée. Merci beaucoup.
Merci. Bye-bye.